Hi guys, I think this is going to be my last set of videos. So this is on diversity, crisis, SI, rape, trauma, abuse, all that jazz. I'm deciding to put all of these together in one lecture, and hopefully it doesn't take too long, and this is just a quick review just to listen in and be reminded of things. So diversity, we have patients of every type of race, religion, ethnic background coming in. And so we need to know that there are 4 things that make up every patient. And so that is their race or physical difference that groups them into a category that is socially significant. We have their identity, how are they viewing themselves, their ethnicity, so what customs, rituals do they feel that they belong to in their perception of self, and then what kind of language, roles, and relationships and just the dynamic of patterns that they have, which would be their culture. So you as the nurse, for every patient that comes in, we need to establish cultural awareness, cultural sensitivity, and cultural competency. So awareness, I need to be aware that maybe this patient does have significant beliefs to them, and maybe those complicate their medical conditions. And so providing really good education and making sure that my patient is interpreting what I'm actually saying. I don't want to, say, make sure you go home and drink a lot of water, and they take that as all I can drink is water. So just making sure they're getting the clear message of education. Cultural sensitivity, just being thoughtful, showing kindness. If a patient, for some reason, likes to be 10 feet apart from you, and so just maintaining that, and asking and figuring things out. We want to just show that we're being inclusive and we're showing equality with all of our patients. And then cultural competency. So you want to know, what are my own biases, right? So there's some religions that, the male speaks for everybody, so the husband's answering all the questions for the wife. And as a nurse, sometimes that can be hard because you're just, you want them to answer for themselves, and you're like, why are you not? But that's their religion. That's how their family dynamic works. And so just recognizing your own biases before you enter their room is super important. And then you want to tailor your nursing actions to effectively deliver care. So if they need, prefer care in the evening, then that's what we're going to do, as long as it's not, a priority intervention or things like that. So just overall looking at your patient and asking them, what do they need from you? What beliefs are important to them? What can you do to support them? And just not stereotyping that, every patient maybe who wears a hijab needs to have it on 24/7, or, are you able to take it off for a procedure? And just ask them their preferences and how things work for them. Axonophobia is disliking people from a certain country and stereotyping. It's really sad, but it does happen. So again, we're looking at our own biases. So people within the community, there are social determinants to health. So economic stability, education, health, resources, environment, those all come together and cause health indicators within a community. And so how can we as a nurse help them? We can provide maybe resource services, flyers for Meals for Wheels. We can use an interpreter. We can just, give them the support they need, education, and things like that. And then the last thing is just 3 important things to remember when going into any patient's room. Communication, space, and time. Some patients love verbal communication. Some patients, like I said, only their husband talks, things like that. So just knowing who's speaking, knowing what language they're speaking in, having a professional interpreter. We never want family to interpret. If there's no other choice at all, then, that's better than nothing. But every hospital should have an interpreting services, because we want the patient to hear exactly what we're saying. And you never want to talk to the interpreter. You want to talk to the patient, and the interpreter will interpret. But it's you having a conversation with the patient. And then space. So knowing how much some people have no personal space boundaries, and they like touch, and they need that when they're being cared for. And other patients need space. They have personal boundaries, and you shouldn't go into their personal space. And then time. Just some cultures are really good on time. They're always early, where some cultures maybe timing isn't huge to them, but we need to educate them that timing is important here to make your appointments and to be on time and to be scheduled for appointments, procedures, and things like that, that we work in a timely fashion. So that's what I had on diversity. I'm going to talk about crisis and suicide. So a crisis is a disturbance caused by a stressful event or a threat when normal coping mechanisms have failed. It's acute and time-limited, affecting the ability to function, and it presents an opportunity for personal growth. So let's look at this in a positive way. Maybe we'll learn new coping mechanisms. So there's 3 different types of crisis. We can have a maturational, situational, or adventitious. And adventitious, I think like an adventure, right? So that's a catastrophic, violent in nature. So think about like a hurricane, a fire, a war, natural disaster, something that is huge, big, COVID, out of everybody's control. That can cause a huge crisis for people. Situational is external and unanticipated, so something happening outside of yourself. So maybe it is a divorce, maybe it is a loss of a job, maybe it is the death of a family member. So things like that, financial problems, a divorce, any issues that are happening outside of oneself that are not planned or anticipated. Versus maturational, this is something that's, a crisis within yourself. It's when you're going through the stages of Erik Erikson and you need to make new coping mechanisms to reach the next stage. So things like puberty, childbirth, retirement. So those were the stages of Erik Erikson. So when a patient has a crisis, there's 4 phases. So phase 1 is the crisis itself, right? We have an issue. Our self-concept is threatened. We're having an increase in anxiety, and we're figuring what defense mechanisms can we use to fight this. Phase 2 is, okay, we're using these defense mechanisms. They're failing. We're getting more anxious, and we're just going to do trial and error with coping mechanisms to try to beat this crisis. Phase 3 is we're still doing the trial and error. Everything is failing. We need to stop, reassess the situation, and then that's typically by the time the patients will have panic anxiety level. And then phase 4, we're depressed, we're exhausted, confused, and SI can occur because they don't know what else to do. They're just so exhausted from all of the anxiety they had trying to fight off this crisis. So what are we doing for these patients? We're going to assess the threat and their personal coping skills, right? What have you used in the past? What have you tried? What haven't you tried? We're going to assess my own bias, always with every patient. And then who do they have in their lives to support them? Is there anyone I can call for you? Who's typically is your person that you go to when you're dealing with a crisis? Reassure them that they're safe, right? The emergency room is typically where you're going to see these patients. You're going to reassure them that they're safe, that you're there for them. This is the safest place that they can be. You want to assess them for SI and HI. SI, maybe they're in the phase 4 of their crisis. And we want just a calm environment, maybe dim the lights. Don't turn the TVs on. Don't have a million people going in. Leave the door open or cracked. My hospital has see-through glass doors in all of the psych rooms, and so that's a safe way of seeing the patient, but also providing a quiet environment for them that they don't have to hear everything that's going on the other side of the emergency room. And that is that. So now suicide. Suicide is the 10th leading cause of death, and it's an intentional act to end one's own life. Who's at risk for suicide? So actually, in elderly are increased for suicide risks. It increases with age. Typically, it happens with males, most likely, divorce, mental illness, the white population, religion, and physical health play a huge indicator in it. So we just talked about religion, and so some religion believe that it's a sin to commit suicide, and they would be strongly frowned upon. Their family, maybe it would bring their family shame, things like that. And so you can see a decrease in suicides in those people's population just because of the role religion plays in it. So now we're the nurse, right? Oh, I'm sorry. Other at risk is serotonin levels, family history, and an SKA2 gene. So now you're the nurse, your patient just entered the emergency room. So we're asking them suicidal, homicidal ideation. We're asking them if they have a plan. Do they have a history of an attempt in the past? If they do, that places them at an even bigger risk of being completing a suicide if they have a past attempt. We want to watch out for covert or concealed behavior and overt or obvious behavior. So think covert, concealed, the 2 C's, overt and obvious, the 2 O's. A covert statement would be, I'm so happy that I gave all my stuff away. My house feels better empty, right? We don't want patients giving all their belongings away. That's something that would be suspicious. Versus an overt would be, everyone would be better if I'm dead, right? That patient's obviously claiming suicide. What are their history of coping skills? And then what are my own biases? You know, maybe I had a brother who committed suicide or a family member who did, and so I might have personal biases, and so just to be able to separate those. So now during their stay, what's going to be the nursing care that you do? They're going to be changed into safe clothing. So nothing with strings, no pant strings, no clothes, no underwire and a bra, earrings, necklace, jewelry, shoelaces, none of that. We change even their socks because, you know, patients do sometimes hide things in socks. And so we're giving them new clothes, new socks. They're going to have a one-on-one sitter, and their door is going to remain open. Or like I said, my emergency room has clear glass doors, so then we just see the patient that way. Even when they're using the restroom, they're going to leave the door cracked for their own personal privacy, but the door will never be closed. We're going to put them in an SI safe room, so whether that being, you know, your hospital has a metal gate that goes down and covers all the medical supplies, so it's basically just a room with nothing in it, or you have to personally remove all of the medical equipment when the patient goes in. You want to search them, you know, maybe shake out their sports bra, shake out their underwear, making sure that they don't have anything on them that could cause damage and they're not hiding anything. We want to assess hopelessness. So basically, a patient can say, oh, the glass is half full or half empty. Hopelessness would represent them saying that there's not even a cup there. There's no water. There's no cup. We want to teach them about health promotion, and we want to give them empathy. So for prevention, we're going to offer support, information, and go to schools and just educate them on signs and symptoms of SI and really educate our vulnerable populations. So that's going to be high schools, maybe even elderly clinics and things like that. Our treatment is going to be treat with them when they're in an actual SI crisis. So this typically occurs in the emergency room. And then our postvention, this is unfortunately after a suicide event happened, where we're doing friend and family assessments and assisting them with maybe guilt or mourning that they have, not suicide. Domestic violence. So I have it on child abuse, partner violence, and elder abuse. So for a child who is being abused typically is less than 3 years old, and they're going to present timid, fearful, loyal to the parent. They may blame themselves or have regressive behavior. So maybe it's a 6-year-old who is definitely potty trained, able to go to the bathroom, and then out of nowhere starts wetting the bed at night. They might have somatic complaints like a headache or a stomach ache. You know, often that really has no other cause. Anxiety. And, you know, they want to please their parent. Versus the parent will maybe have few or little friends. They could possibly have a history of a mental illness or substance abuse. They perceive their child as evil. They have no bond with the child. They could be in a crisis situation themselves. And you'll notice that these patients don't leave these parents don't leave their child alone. So maybe they came to the emergency room a couple days after an injury happened. That would spark a red flag. Why wouldn't they come right away if it was an accident, right? Or maybe they're very controlling. They're answering all the questions. Maybe they have a bad perception of their kid, right? Maybe they're name calling their kid or talking down upon their child. You know, that's very unusual for behavior for a parent to do. And especially if your kid's in the emergency room because, you know, they're injured. The last thing you're going to want to do is like trash talk your kid to the nurse. And they don't want to leave their kid alone, right? Because they're afraid that they might get questioned and the child might say something about them. And so it's maybe someone who threatens to leave if they're not allowed to go to x-ray with their child or things like that we're looking out for. And so what does the nurse do? So I'm going to allow the child to express themselves with dolls or drawings. We're going to do our our best. We need to separate the child from the parent because we have to be able to see what we can get from this child, and whether that be, during the time for x-ray, keeping them an extra 5 minutes, maybe the doctor needs to talk to the parent outside of the room, just trying whatever we can do to split them up. We typically do not want to be judgmental. We do not want to have the parent think, that we're out to get them or that we're on to them, right? Because that's just going to escalate the situation from there. We want to always ask the child open-ended questions, and we never want to promise confidentiality because this has to be reported. So anything they tell us is going to be reported. So don't promise them that. And then we can also body map the child's injuries. We're looking for bruises, breaks, scratches that are just inconsistent with maybe their age. Maybe these bruisings are in all different stages. Maybe we see burn marks from a cigarette, things like that we're looking out to. And then any child abuse, you need to be honest with the parent that it is going to be reported to CPS, even unintentional ones, right? Like possible neglect or just unsafe practices. An example is we had a patient who came into my emergency room. They ingested a bunch of medication. It was a child. The mom just didn't have the medication stored in a safe area away from her. The mom brought her in right away, frantic, really cares for her child. But unfortunately, that is notifiable, and it is the law for a nurse to report. So CPS is going to go and check in on them. And so just educating them and being honest with them that is going to be a follow-up. It's not a threat, but it's just, that's the law. I'm just doing my job. Partner violence, it can happen both to male or female. Typically it does happen to female, but we never want to assume it doesn't happen to males. So the increase of partner violence ending in homicide is when the significant other is either A, leaving them, or B, is pregnant. And there's a huge risk for birth defects, unfortunately. So our victims, they typically have low self-esteem and they have a bond with their abuser, whether it be emotional or financial dependency. They become isolated from their job, their friends, and their families. They believe the abuse will stop if they do the right thing. The abuser is jealous, controlling, poor self-esteem, poor social skills, and controls the family finances. So there's a pattern here. So we have the honeymoon stage, which is apology, gifts, flowers, promises, they'll never do it again. We have the tension building, and so this is when there's many little outbursts. You'll feel like you're walking on eggshells. Anything you do, you don't know if that's going to be, real hammer down. And so typically some patients who have been in this pattern just over and over will just do something wrong so they can get a real big beating and then just be done with it, and they know they're going to go into the honeymoon phase, but they just can't be in the tension building phase any longer, which is heartbreaking. And so then serious battering, that's when big injuries will happen to the victim. The victim will try to hide them. Also, there was a question in the Varicose book, where would these injuries most likely happen? The answer was the bikini area. So look for areas that are easily hideable and not visible to anybody just wearing everyday clothing. That could be somewhere where this abuser is injuring them. And then it's just a vicious circle of walking on eggshells, getting a beating, honeymoon phase. The nurse, what do we do, right? So we can't legally report this unless the patient wants to, right? And she has that decision because she's a grown-up, she's alert and oriented, and she is in control of her own decisions for herself, right? She has to report it if she feels unsafe. So we're always going to tell them that, they can always come back. We want to try to separate them, right? Have the husband maybe wait in the waiting room. We have to ask her some personal questions, things like that. We want to come up with a safety plan for them. So in the book, it said that we can have just a small little piece of paper having emergency contact number, shelter to call, things like that. Something really small that they can slide into their shoe, right? Because if they come home from the hospital, we don't know how abusive this relationship is. Maybe he's going to search all of her belongings, and if he finds something, she might get an even bigger beating because he's going to think she told someone on him and things like that. And so we need to give them this shoe-sized little tab. And then also we want to educate them, right? Have a safety bag. So when you do ever hit the spot in your life where you're like, I have to leave right now, my life is in danger, right? So passports, birth certificates, your social security card, What we don't want is them holding on to money or holding on to things that are going to be noticed, right? Because then that's going to increase your partner's suspicion and then cause you more trouble in the end. We want to have a safety place that you can go to, whether it be a friend's house, a loved one's house, a shelter, but somewhere safe that you know you can go to. And then lastly, we have elder abuse. And so this, the greatest number of elder abuse happens to women aged 75 years or older. They're typically white with poor mental or poor physical health. Different types of elder abuse can be the patient presents with malnutrition, isolation, bed sores, fear of being alone or being left with this caretaker. And they could have possibly been once the abuser, right? So if it was an abusive father who's now physically or mentally ill and the son's taking care of him, the son might now abuse him. And so that brings us to an abuser. Typically, they're a middle-aged family member or child of that person. They could have mental health issues or have an overwhelming stress or be in their own type of crisis. And so sometimes it's not intentional abuse, but that doesn't mean it's not abuse, right? And so maybe you're working 2 jobs and you're dealing with all your own stuff, and then you have a mom at home who is sick and you can't care for her, so she's isolated all day. She's not getting turned every 2 hours. You're just so overwhelmed. Your mom has sores now. That's unfortunately abuse. You need to reach out for help. We need to set these patients up for maybe Meals on Wheels, respite care, assisted living, and we need to involve CPS for mandated, no, APS for mandated reporting, Adult Protective Services, because elder abuse and child abuse are the 2 reportable ones. Partner violence, it is up to the patient to report it. Whew. And lastly, sexual assault and sexual violence. So sexual violence is any act of sexual harassment up into rape. And sexual assault is basically an umbrella term for a lot of different types of rapes. So it can be a date rape, acquaintance, marital, or incest, and it's any intercourse with the vagina, anus, or mouth. There are 3 different types of drugs that patients can get date raped with that were talked about in the book. So GBH takes 12 hours to be excreted. So that's a difficult one if you were just such in shock or you couldn't get to a safe place, to a hospital, to report it and maybe out of your system. And then we have rohypnol and ketamine, which take about 72 hours to excrete in your urine, which hopefully if you go to a hospital, they're able to test for it. And basically with these drugs, you have a 10 to 30 minute onset. You're going to have amnesia, euphoria, and a decreased level of consciousness. Who does this happen to? So we have child abuse and incest, right? So 75% of molestations occur at the hands of a family member. Children will present with maybe genital discomfort, fear of being alone, regression like we talked about earlier. So if it's an 8-year-old who can definitely go to the bathroom independently, starts wetting the bed, starts, reverting back to childlike behaviors, that is a huge red flag. Inappropriate sexual behaviors like masturbating and things like that. Taking one's clothes off and just inappropriate touching of others and things would be something to look out for. It isn't abnormal for children to touch themselves when they're first learning about their body, but doing it in a sexual way is very different. And they can maybe have anger outbursts and isolation. So those are definitely things to look out for. Versus young adult rape. So this is going to be typically our patients presenting to the emergency room. We're not going to allow them to change clothes. We're going to hope that they're in the same clothes because we're considering everything evidence. They can't eat, they can't drink, they can't use the bathroom. We don't want anything to unpreserve the evidence that they're coming in with. Collection of all of this evidence in a rape kit can be done regardless if a patient is choosing to press charges at this time. And we want to document quoted verbatim statements. We're taking objective and subjective data, right? Usually you as the nurse, you're doing objective data. But we want to say this patient stated this patient stated that, right? So since we're taking verbatim statements, those are subjective data that we're going to be reporting and putting in our nursing note. We always want to use words like reported, declined, and penetration, and never used alleged, refuse, or intercourse. So there's 2 programs that are put into place for patients who are suffering sexual assault. So the SART team is a team that works in collab with mental health agencies, crisis support, emergency rooms, police stations, and things like that. And basically, they all come together to support a patient, and they offer resources. First, the SANE. So we have a SANE nurse, which comes to the room, and she's the one who performs the rape kit. She is able to collect forensic evidence, and it takes about 2-3 hours to perform a SANE kit. There's so many questions that have to be asked. You know, they even brush like your little eyelashes, everything. They're taking samples of anywhere, anything. We want to ask them, you know, pictures are going to be taken, so we need consent. We're going to support their psychobiological needs. We're getting permission for all of this evidence we're collecting. And then also the SANE nurse is able to provide expert testimony in a court for this patient. And then victim characteristics. So what may this victim appear like? So they might be impulsive. They might be antisocial. They could be sexually aggressive. They might prefer impersonal sex. And they might have a childhood of abuse history. And so that's really sad. So rape trauma syndrome. So we have an acute phase and a long-term phase. So in the acute phase, this begins immediately after a crisis. The patient's in shock. They're numb. They may appear calm, impaired cognitive function, and generalized physical reaction, maybe some of those somatic complaints. They're just really like numb and in shock and disbelief that this happened to them. They really don't know how to act, kind of confused, dazed. Versus the long-term phase, they're having flashbacks, nightmares, phobias, social withdrawal, hypervigilance, sleep disorders, and risk for SI. This is really looking at more of the PTSD aspect of it with the flashbacks, withdrawal, hypervigilance, and sleep disorders. And so you as the nurse, you're just going to support the patient, give them resources, support groups, and things like that. And that's everything I have on those lectures. I hope this helped someone, and it's a quick 28-minute video with about 5 lectures worth of content in it just to talk about it and hear it. Thanks, guys.